All right, folks. Thank you for coming to the 2 o'clock webinar on ballistics for EMS. Our presenter today is going to be a man who needs no introduction, Dr. Michael Bohanske, a member of the EMS division here at Maine Medical Center, Portland. We'll give him the floor. Mike.
Perfect. Thank you. Do you have any administrative things you got to say before we get started? Things you need from people?
I'm gonna throw some notes in the chat, but obviously, if you have questions, throw them in either in the chat or the QA. If you could shoot your name and license number in the chat, also that gives us the registration piece that we need to show that you attended. Also, if you're from out of state, if you can just shoot me an email if you do need a certificate, so I can make sure I get you one printed. And I'm going to print all that in the chat also. And I think we're good to go.
Perfect. Awesome. Thank you, Eric. I think the only other thing I remember from our previous ones of these is if you've got multiple people in a room listening to a webinar, make sure all the names and license numbers go in that chat so you all get credit.
That would be the other
perfect. Well, welcome. Thank you, everybody, for coming on this, at least here, is very, very gloomy Friday afternoon. I appreciate everybody coming. As Eric said, my name is Mike Bohanske. I have worn a bunch of hats in the region. I think the hat that I'm going to wear today is primarily that of my medical directorship with the Southern Maine SWAT team. But I'll introduce this topic a little bit and kind of how we got here. The topic we're going to cover today is about ballistics and EMS. And the idea for this really came after the Lewiston shooting, focusing not on, certainly not on trying to make anybody experts in the functionality of weapons or how guns work, but recognizing that there's a lot to that matters when we are starting to think about how we're going to care for patients. And so this is intended to be a little bit of a primer on ballistics, how bullets work, what bullets do, so that then when we start talking about patients, we can start getting a sense of how that's relevant. Before we get into anything, I do want to start by saying happy EMS week. I'm very excited to be presenting here at the tail end of EMS week. I hope everybody has had some good festivities. We're very excited that we get an opportunity to speak to you regularly on webinars, but especially this week. It means a lot that people are taking their time to attend to these talks. And so thank you for being here and thank you for what you do every day. My other disclaimer from the beginning here is I don't have any financial disclosures. I also am not a firearms expert. So I'm going to tell you what I know, what I've researched, why I think that's relevant when we're talking about how we care for patients. But you certainly may be more expert in firearms or their functionality than I am, in which case I'm excited to learn from you. As Eric said, any thoughts, questions, put them in the chat. The way this webinar format works is that's the only way we can interact with each other, is through that chat or Q&A function. I can't unfortunately see anybody, but through that, Eric can pause me and interrupt me with questions as we move along. All right. Goals for today. We're going to cover a couple different areas. The first one is we're going to kind of introduce the idea of kinetic energy, why that's relevant, and what that means for us as far as wounding patterns or power behind some of these weapons. We're going to talk about ballistics. We're going to define what it is. We're going to talk about the different kinds of ballistics, whether that's internal, external, or terminal. And I'll tell you what each of those are as we kind of get there. We are going to get into a little bit of bullet design and what that means for the effects on terminal ballistics when they eventually hit their target. And then terminal ballistics, when we were talking about injuries on patients, we will change that terminology and call it wound ballistics. And so we'll talk a little bit about wounding patterns and why this is relevant when we're considering potential injuries or actual injuries to patients. The other thing about why this is really relevant to us, here's some local data from Maine Medical Center in Portland, and that is that traditionally we've not been a place with a lot of penetrating trauma. But those numbers have essentially doubled if we look at kind of the pre-pandemic and post-pandemic years. So up until 2020, a high number of 26 patients in a single year who had sustained a gunshot wound. And then since 2021, we've had numbers that have been significantly higher than that, with 48, 45, 36, and 49 separate patients coming into this hospital with gunshot wounds. So obviously this is a relevant topic for all of us all of the time, but certainly seems in our area to be more relevant the last few years than it had been previously. Okay. There are hundreds of variations of ammunition out there. Things that we're going to discuss, this variability leads to different mechanics in the gun, different flight patterns, and ultimately different wounding characteristics. We are certainly not going to cover every kind of ammunition out there, what different ammunition can do. We're going to cover the broad strokes about how these work, but please recognize that there are going to be a number of different types of these things that exist that we're not going to be able to cover today. All right. Every good EMS talk starts with an anatomy slide, so we're going to start with the anatomy of ammunition. The anatomy that we're going to talk about today comes in two basic styles, handgun and rifle, but I want to introduce you to a couple of different pieces and how we're going to describe them. So first of all, the bullet, or the number 1 that you see on top here, this is the missile or projectile. This is the heavy piece of metal that gets fired out of the weapon and travels through the air. The cartridge describes the casing, or the large piece of usually brass that is hollow and designed to hold gunpowder. Gunpowder sits on the inside. The bottom of the cartridge is a primer. This is the area that actually causes the small spark or explosion to light that gunpowder. And then when that gunpowder ignites and explodes, it increases the pressure in here in terms of gas and pushes that bullet out on the side. As you can see from just a side-by-side, rifle rounds compared to handgun rounds are comparatively larger. The idea there is that rifle rounds are designed to hold significantly more gunpowder than a comparative handgun round. So when we're talking about different types of ammunition, we'll talk about kind of those two big categories overall, recognizing that more gunpowder means bigger explosion means more force pushing that bullet or projectile out of the weapon. All right. Why does force matter? Force matters for us because there are a number of factors that play a role in which a bullet causes damage, but by far one of the largest components affecting wounding capacity is the kinetic energy of the bullet. This is the only calculation that we're going to throw up the entire presentation, but I do want to focus on it here for a second. And that is kinetic energy, the energy that is going to be going with the bullet and then potentially transmitted when it hits its target, is calculated by this equation. It's 1/2 the mass times the velocity squared. The reason that this is relevant is when we're talking about the designs of different ammunition, the two biggest things that end up getting altered with different bullet designs or different ammunition designs is how much mass is actually in the bullet at the end of that, and then how much velocity it's going to have when it leaves the gun. And that velocity is really controlled by the amount of gunpowder that is available in that cartridge. A little bit of what that looks like when we actually do the math. So I want to introduce two different types of ammunition that people will be familiar with. The .22 Remington, this is every Cub Scout, Boy Scout learning to shoot weapon, is a .22. This is a very classic small rifle round used to put holes in paper downrange. The weight in grains that bullet will classically weigh is something like 40 grains. And leave the gun at a muzzle velocity at 1,180 feet per second. So we take those numbers, we take the mass and we take the velocity and put it into the kinetic energy equation. It comes out with this number of 124 foot-pounds of kinetic energy. Now we compare that to something that comes out of a military style rifle. Here they use the weapon, the M16, but a .223 is the ammunition that it fires. The bullet is actually very similarly sized. You can tell it's only 55 grains. It's not significantly heavier. It's 37% heavier. But what you'll notice is the muzzle velocity coming out of that is traveling at 3,200 feet per second. It's 2.5 times faster than the .22 round leaves the weapon. What that means is that when you put that into the kinetic energy equation, you get this number, 1,248 foot-pounds per second. It is tenfold more kinetic energy coming out of that ammunition than there is the .22. So very similar size projectiles, relatively very different muzzle velocity, but because that muzzle velocity is squared in the kinetic energy equation, we're talking about a significantly more kinetic energy. All right, the bullet itself, the projectile, is made of a heavy metal, most often lead or some sort of lead alloy. And due to the fact that lead melts and deforms at lower temperatures than other metals, we most often see lead coated in a harder metal like copper, as you see here. The term full metal jacket, you may have heard, describes the coating that's going all the way around this denser, harder core. And that full metal jacket is here to help ensure that that lead doesn't deform either in the gun or as it is traveling, and maintains this shape as it moves. Additionally, some bullets are intentionally designed to deform. Like the bullet seen here, which is a hollow point bullet, meaning that it's got this opening at the end. So it's designed that as it starts to hit something, it will deform and open up, causing both the copper coating as well as the lead on the inside to deform and mushroom upon impact. This does a few things. First of all, it deposits more of its kinetic energy into the target. It also increases the physical size of the projectile as it enters the target. So rather than traveling through in its original shape, it's going to start traveling through the target in this much larger shape. And as a result, causing more damage as it does that. This results that those two things, depositing more kinetic energy and the increase in size upon impact, causes more takedown power. This lessens the likelihood that the bullet will travel far after it hits its first target. It's much more likely to slow down or stop in its initial target. And so we see this used an awful lot, especially in civilian law enforcement. We see this very intentionally chosen as a round to deposit its kinetic energy and make use of that takedown power. All right, a little bit of an example of what this looks like. These are some drawings of what bullets look like as they travel through ballistic gel. I am going to introduce some videos in a little while where we get to see what bullets look like traveling through ballistic gel. But I want to start in the top here. We'll talk about these full metal jacketed bullets. So these are ones that are not deforming as they travel. As a result, we compare a rifle round versus a handgun round. Both of these are going to enter at a high speed. They're not going to deform. They are going to travel much further. And they will cause less local damage, less local deformity, and a little bit of a larger permanent cavity as they travel through. So that's what these look like as they are traveling through because they are not deforming. However, if the bullet is more like those hollow points we looked at a second ago, or some variation of an expanding bullet, it will deposit more of its kinetic energy on impact. It will not travel as far, and it may cause more cavitation. Again, we'll introduce that term a little bit further in a second here, but just to show the side-by-side comparison of what a expanding bullet looks like as opposed to one that does not expand, it is going to cause increased size of this cavity early, not travel as deep, regardless of whether it is a handgun round or a rifle round. And again, we'll kind of show what those images look like as we introduce some ballistic gels here in just a minute. All right, 12 minutes into a talk, I should probably introduce the term ballistics. The study of the ballistics is the study of the natural laws governing projectile missiles and their predictable performances. We break this down into three general categories. Internal ballistics are any of the actions that are happening inside of the firearm. External ballistics happen from the end of the muzzle until the bullet hits its target. And terminal ballistics are what happens after it enters the target. Again, the term wound ballistics I used before relates specifically to the study of the missile's effect on any sort of living tissue, but three different kind of categories we're going to break this down into here. So first, internal ballistics. We're talking about how a bullet is designed and what the components of ammunition are. This is what it looks like inside of kind of a cross-section of a weapon, where you've got that cartridge here full of gunpowder, you've got bullet in the end of it, and then you've got barrel coming out the end. In this case, it is what's called a rifled barrel, or one that's going to create some spin of that ammunition as it leaves. Firing pin is this piece sitting back here, and that firing pin will hit that primer we identified earlier, start that explosive force, and is by igniting the gunpowder. As that gunpowder ignites, it heats up, it creates gas. All of that gas builds pressure inside that cartridge, forcing the bullet the only direction it has to go, and that's downrange, down through the barrel. As it goes, it travels with a bunch of that hot gas and any sort of unignited or unexploded gunpowder. And so this is where we'll see any sort of flames or hot gases exiting out of the end of a weapon coming with it as it fires. Once it leaves the barrel, we're now talking about external ballistics. This is what's the bullet going to do as it travels. And what it's going to do as it travels relates an awful lot to the conditions around it, how far it needs to go, and what that bullet design looks like. It's going to meet resistance. We think a lot about air resistance and gravity being the two primary forces, but there are additional forces that are playing a role here, and that includes how much that bullet is rotating or spinning as it travels. And that relates an awful lot to the design of the weapon and that rifling of the barrel. And then how much it's going to move in any of the planes, whether it's moving in a horizontal plane about an axis or even a version of a tumble. This can do a couple of things. Sometimes it will be more of a precession. This is the tip of a bullet kind of moving in some sort of spiral or circular pattern, but overall staying on its course with the tip heading towards the target and the tail kind of following behind. Or bullets can have a significant amount of yaw or tumble to them, causing them to even go kind of head over heels as they are traveling downrange. These characteristics of bullets and their associated firearm are taken advantage of in weapon design. If you want a weapon that you use in close proximity, you don't aim, and is intended to spray bullets toward your target in hopes of hitting something, you want a bullet that's going to have a lot of yaw or precession or tumble as it travels. What that does is it means the bullet is effectively bigger and more likely to hit its target if it is traveling in one of those fashions and moving in a bigger direction because of the amount of precession or tumble that it has. If, however, you want a bullet to travel a very long distance with no change in trajectory, you need the precession to go away, you need the yaw to be non-existent, and you also want to take advantage of some of that rotational velocity of the bullet in a predictable fashion so that you know how much speed this bullet is going to maintain over time and how that's going to affect its ultimate ability to hit a target that's very far away. Okay, we talked about internal ballistics when a bullet is in the weapon, external ballistics as it is traveling. Now we kind of get into the meat of this and start talking about terminal ballistics. A few things that we do want to consider, though, in most civilian scenarios. One is our proximity is relatively close in civilian gunshot wounds. Pistol shots that are fired less than 50 yards and rifle shots that are less than 100 yards will have an impact velocity equal to their muzzle velocity. What that means is that in the civilian world, the vast majority of the shootings that we are seeing are happening in these close distances. These are not long distance shots, so the bullets don't have any time to slow down. So when we're talking about what a velocity of a bullet is, it's whatever it left that barrel at based on the type of cartridge and type of gunpowder that was in it. We think a lot about impact velocities. So any sort of impact velocity above 150 feet per second will penetrate skin. Any impact velocity above 195 feet per second will break bone. So we think about those numbers a lot when we're talking about kind of what bullets do over time. And then upon impact, the terminal ballistic qualities of the bullet really come into play. If the bullet deforms, it will mushroom or expand like we saw before, causing a bigger wound cavity. It'll slow down, depositing all of that energy into the tissue and causing all of that significant tissue damage. So that's what we see in this top part of the diagram here, is a bullet that is deforming upon impact, increasing in size as it does, but because it is increasing in size, it is creating a bigger and bigger wound cavity as it travels and slowing down, depositing a lot of that energy into the tissue, and that alone causing tissue damage. Bullets may also break apart, causing fragmentation. These small fragments can wreak havoc on the tissue as it's no longer causing damage just along a single path, but now creating damage into a number of different areas as these little fragments kind of move throughout the tissue. Or if the bullet's designed to tumble in the air, like we talked about before, or some of them are designed to tumble upon impact, it may deposit significant energy and cause a wound cavity that's much larger than the diameter of the bullet as it continues to tumble and create this this motion as it's moving through the tissue. All right. So I do want to introduce a little bit about permanent cavities versus temporary cavities. This will make much more sense when we start seeing the ballistic gels here in just a second. But mostly what we've been talking about at this point is permanent cavities. Permanent cavity meaning that something physical, the bullet or pieces of the bullet traveling through the tissue, destroyed tissue as it traveled through and caused this hole or path as it passes through. So that's what we've been looking at on all the previous diagrams. When we're talking about handguns, we're only describing a permanent cavity. However, anything that is fired at a rifle speed now has the velocity to cause what we call a temporary cavity. This is caused by cavitation, or the shock wave that comes with that significant velocity entering into tissue. So that's what's described here with this kind of outer line. This is that temporary cavity, and this is the expansive forces coming from that velocity. So this will still potentially cause tissue damage depending on what kind of tissue is being impacted. We think about the tissues that are most affected by this being our air-filled structures. So things like lungs or bowels are significantly affected by the temporary cavitation effects, or any sort of tissue that doesn't have elasticity. It's not going to have the ability to bounce back afterwards. So we think a lot about liver and spleen, solid organs, blood-filled organs that are inherently do not have any elasticity to them. So if the cavitation of forces affect those organs, they can cause significantly more damage than just the path that the bullet actually passed through. All right. We are going to sneak over for a video at this point and hope that YouTube plays friendly with Teams. And I'm going to show you a couple different videos. First one is just trying to exemplify what we were talking about with the difference between a permanent and a temporary cavity. So I'm going to introduce that here, and we will go ahead and play.
They are the permanent cavity and the temporary cavity. The permanent cavity is also known as the wound channel or wound track. This is simply the tissue that is cut and crushed by the bullet as it passes through. If the bullet hits something important enough, the target will be incapacitated. The larger the bullet, the more likely it is to hit something important. Larger permanent cavities also cause more rapid blood loss, but any bullet can be effective with good shot placement and adequate penetration. In ballistic gel, adequate penetration is considered to be at least 12 inches. The temporary cavity is the one that's most often misunderstood. Shortly after the bullet impacts, it creates an opening in the tissue that lasts about 10 milliseconds. It looks really impressive in ballistic gelatin with a high-speed camera, but the actual wounding effects are often exaggerated. The severity of damage caused by the temporary cavity is somewhat unpredictable. It depends a lot on the shape, size, and velocity of the bullet, as well as the size of the person and the organs affected. Most tissue in the body is fairly elastic. It tends to snap back into place right after the bullet passes through with no lasting damage. To cause permanent damage, the temporary cavity has to stretch far enough to overwhelm the elastic limit of that tissue. Handguns typically do not have nearly enough velocity to create a temporary cavity that will make a difference within a few seconds of a gunfight. That's one of the major distinctions between rifles and pistols. With pistols, we can only count on the permanent cavity. An expanding hollow point will create a wider permanent cavity, but ballistics experts debate whether even that has any effect on the outcome of most cases. What they do all agree on is that shot placement and penetration are by far more important than any other considerations. Here's an expanding 9mm in FBI spec gel. The temporary cavity makes a nice spiral shape that looks pretty intense, but let's see what it actually left behind. It's a good permanent cavity that just makes it to 12 inches. If it can do that consistently, this would be considered adequate by handgun standards. The tearing from the temporary cavity maxes out at about 2.5 inches in height and width, and it's 5 inches long. That's fairly insignificant compared to what we can count on an effective rifle bullet to do. The question everyone asks.
All right, I should have given a little bit of a disclaimer. Not a medical person, not an EMS person. This is a bullet person who's helping with this video, but I do feel like his explanation of exactly what the different cavity types here is really accurate, and nothing really exemplifies the types of cavities we're talking about in drawing as opposed to these videos, which is why I think the video component of this is helpful and included it here. I do want to show a couple of different types of ballistic gels now that we've sort of seen what those look like, and so I'm going to fast forward here just a little bit and introduce what a rifle round looks like. So let me put this up and we'll talk about what that sort of velocity and temporary cavities look like.
Let's see how that looks in gelatin. This is a Barnes TSX all copper expanding 223 Remington. It opens up shortly after impact, which creates drag that slows the bullet down, and the energy is transferred to the surrounding tissue. This one has also fragmented a little. The biggest chunk does exit the back of the gel block, but it's not moving very fast. Most of its energy was used up in the block. As far as I know, there is not a specific pass-fail standard for the temporary cavity like there is for penetration. I get the impression that most ballistic experts would probably say what we get from an expanding 223 is close to the minimum threshold. The ones I've seen tend to be at least 4 inches in height and width and 7 or 8 inches long. That's pretty much what we have here in this 223 Barnes. Now let's...
All right. I'm just going to back up to that image there for a second. So I find this to be really impressive, especially after we saw that first ballistics gel with a handgun round going through it. Now comparing that to what the rifle round looks like. Obviously, rifle round penetrating all the way through this 16-inch long ballistic gel. So it's having a lot of velocity as it enters. It's slowing down as it goes, but enough velocity and force to continue exiting out the back of the ballistic gel. You saw that temporary cavity form as it went, and you see that here with kind of the light red discoloration when they dyed this. But then that permanent cavity as it passes through. A permanent cavity diameter is relatively small because this is a small diameter projectile traveling. However, it can cause damage in a number of different areas as it's passing through deeply, but also you can tell fragmenting as it goes. So leaving pieces as it goes that are changing trajectories and going to be impacting and affecting any of the organs as it passes. So impressive round. This is the 223. This is that M16 or AR-15 round that is very classic and common. This is the one we were talking about when we were talking about its kinetic energy versus a 22 kind of target rifle round. I'm going to show one last video. Last video here is of a 308 round. I put this up to show what happens when we start adding significantly more velocity and mass at the same time. We think about the kinetic energy equation. Remember, it is 1/2 mass velocity squared. So if we are increasing mass, we are increasing our kinetic energy. If we are increasing velocity, we are increasing our kinetic energy in a squared fashion. So a larger round is going to have significantly more force. And unfortunately, this is very similar to the round that we saw used at the Lewiston shootings, but I think gives a good perspective of what more forceful ammunition can look like. So let me just skip ahead here.
So let's look at a cartridge that has a lot more energy to work with. Here's another Barnes TSX, but this time it's a 150 grain 308 Winchester. The bullet expands, creates a huge temporary cavity. It actually tore through the bottom of the block and messed up our tabletop. We would really need a larger gel block to adequately test cartridges like this. The leap from 5.56 to 308 is a pretty big one. Another question I hear all the time is...
So, impressive amount of that expanding cavity, the temporary cavity from that cavitation force. Sorry, just trying to get back where he dyed it. There it is. He described the fact that it went out the bottom of the gel. So obviously this is a medium-sized gel, but he is getting enough force that really causes a significant amount of cavitation, or a significant amount of tissue damage from that expansion that we would expect from this, especially in some of those more sensitive tissues. We're thinking about lungs or bowels that do not tolerate that kind of expansion. And then the permanent cavity, because this is a larger bullet, is significantly larger in diameter as it travels through. This particular one doesn't fragment, doesn't do any significant deformity, but travels through with a lot of velocity and a lot of force. Okay. Let's move on a little bit. Okay, we're gonna take a brief historical tangent. As I started getting into expanding bullets, anything that's going to deform as it changes, as it travels through the air, as it hits its target, I started seeing an awful lot of references, and I had to go back and learn about this myself. So the first hollow point expanding and partially jacketed bullets ever produced were done at the Dum Dum Arsenal in Calcutta, India. This is used by the British Indian Army. So this is 1898 at the time. And so if you've ever heard the term dum-dum bullets used since then, it's to reference these. These are relatively soft lead bullets, again, partially jacketed, but the first ones that we saw used in a military fashion and intentionally expanding. In 1898, the German government lodged a formal international complaint against the use of these bullets, stating that the wounds produced were excessive and inhumane, and thus violated international laws of war. Their argument at the time was that any soldier who had been shot was a gentleman and was going to stop fighting and was going to lay down, but that these wounds in particular were causing so much damage, such large cavities, that it was inhumane, that you were not fighting like a gentleman in war if you were causing large wounds. As a result, in 1899, this went to the Hague Declaration. It's now included in the Geneva Convention. This language is upheld today with only fully jacketed rounds used by armed forces that abide by the Geneva Conventions. So interestingly, a very different world, very different perspective in the military environment, military ammunition, as opposed to civilian law enforcement, when civilian law enforcement is intentionally taking advantage of those expanding components of ammunition, and the military is avoiding it based on this now ancient declaration. All right, that's enough of the strange tangent. I want to get to a little bit more kind of modern wounding patterns and introduce you to this paper that was published in 2016. Reed Smith and his colleagues listed here went and tried to perform a profile of wounding and civilian public mass shooting fatalities. A little bit of definition here. So first of all, the FBI defines a mass shooting as anything with 4 or more deaths, not including the shooter. So that kind of sets the parameter for the type of injuries or the type of events that they were looking at. And again, this paper was published in 2016, so things that are going to recently come to memory were not included in this. What they went to first was went back and started looking at some of the military data, specifically Vietnam, and then Operation Iraqi Freedom. And interestingly, the fatal injury patterns in combat between those two very, very different conflicts stayed the same. Now, what that means, and what we're seeing in the graph behind, is that if we compare those two conflicts, they have very similar fatal injury patterns. 38% in the head, 24% in the chest, a smattering of abdomen, extremity, face, neck, and then certainly a proportion of people who have fatal injury patterns in multiple areas of their body. But this is different. This is war zone. This is young, healthy soldiers wearing ballistic vests, helmets, being shot at by high velocity weapons, and exposed to IEDs. However, this is the data that we use to say that 15% of casualties in the military setting have potentially survivable injuries, including extremity hemorrhage. Of that, 9% of the patients were found to have extremity hemorrhage that was potentially salvageable. Some airway obstruction, some pneumothorax in that movement too. So expectedly, that's the data that we use to extrapolate to the civilian world and say, in the pre-hospital setting, in the civilian world, we need to spend an awful lot of time training on tourniquets, bleeding control, stop the bleed techniques. So what Reed Smith and his colleagues did was say, okay, this is what we have said. We've extrapolated this data from the military world for a long time. Does that actually line up with civilian shootings? So they went back and tried to find, again, anything with 4 or more fatalities, not including the shooter. They looked and ultimately found a total of 56 different events in their study period. They were looking up until 2013. And recognizing that prior to 1999, which is when the Columbine school shooting was, there really were no detailed reports of school shootings. So they found all 56 of these events in their study period and said that the way that they wanted to gather data and look at wounding patterns was to go directly to the source, which was the autopsy reports from the medical examiner. So they filed a ton of freedom of information requests directly to the medical examiners, asking for de-identified autopsy reports so that they themselves, as the study authors, could go in and look at the wounding patterns and identify whether or not it correlated with the military data. Unfortunately, medical examiners vary community to community, state by state, so the laws around freedom of information request like this, or whether that data was even ever recorded in some way other than aggregate, varied. So they were only able to get their hands on 12 total events. So these are the events that they were able to get the autopsy reports from. This totals 139 fatalities. And on average, out of this combination of shootings, there were 2.7 wounds per victim. Now, again, they had autopsy results. So they went in and looked and said, okay, where were all of the wounds by anatomic location in the distribution of these civilian shootings? 29% of them were to the chest or upper back. So we're talking torso injuries. 29% to the head, 20% to the extremity, 14% to the abdomen or low back, and then 9% to the face and neck. Of those, the distribution of fatal wounds demonstrated that 90% of the victims had non-survivable injuries in a single anatomic region, and only 10% of the patients had died of multi-system trauma. You'll notice the spread here is 39% of the fatal wounds were head injuries, 38% of the wounds were chest or upper back injuries, with very few injuries in the face, neck, abdomen, or like I said before, multiple regions. This is interesting and is very different than what we see in the combat environment, but certainly fits well with what we'd expect when people are not wearing ballistic armor. They then ask the question, okay, of all of the autopsy results that we have, do we think by expert opinion the patient would have potentially survived if they had received two things? The thing was pre-hospital care within 10 minutes of the wound and arrived at a trauma center within 60 minutes. So were these truly preventable injuries or truly preventable deaths were out of all of the patients who died in these conflicts? Unfortunately, they only found a handful, and these are the ones they found out of those 139 victims. And so you will notice here that the types of injuries that are identified as being potentially salvageable or potentially the patients could have survived from were not extremity trauma. It was not the kind of potentially salvageable patients that we saw in the military environment where cat tourniquets and close hemorrhage control seem to be the most contributing factor. A lot of these were chest injuries with tension pneumothoraces or hemothoraces. These were airway problems with face, neck, and upper chest kind of trauma. So a very interesting, different kind of pathology. Now, I will say this is a tough study for us to look at and to know how applicable it is to what we do as far as changing our teaching or changing our protocols. You'll notice because of the way the study was done, it was all done from autopsy data. It only includes dead patients from these conflicts. So anybody else who was shot and survived is not included in this data set. So good EMS care at these events or good hospital care when the patients arrive at the hospital certainly changes the outcome of patients and it's just not included in this data set. Unfortunately, in the world of civilian mass shootings, very little of that data is captured in any other sort of aggregate fashion to say from a single incident of all of the patients involved, how did the patients do, whether they were fatal injuries or non-fatal injuries, what did that entire wounding pattern look like? So this actually serves as one of the better studies or better sources of information we have, again, recognizing that it only includes fatalities. Okay. I mentioned before, we put a lot of time and a lot of effort, and I certainly do not want to discount all of the time and effort we do into things like tourniquet training and stop the bleed, but it's very interesting to look back at this retrospective study of autopsy results and recognize that unfortunately tourniquets would not have saved any of those patients in those 12 different incidents. The same study team then took their methodology and applied it to the autopsies performed after the Pulse nightclub shooting. You'll notice this is a very different wounding pattern. So again, total injuries over here on this side of the screen, and then possibly preventable death injuries here. So first of all, this is a lot more injuries per patient on total. They noticed 6.9 wounds per patient and many, many more extremity wounds. So almost half of the patients had extremity wounds. Again, they do this here as total number of wounds rather than percentage, but you can tell it's making up almost half the pie. And then when you extrapolate that over to patients who had possibly preventable death by organ injured, the folks that we're talking about as folks that we can get to and affect care with early, vessels in the extremities, these are things that are likely able to be treated with a tourniquet. Lung injuries, this is something that may benefit from something like a needle decompression, and then some single kind of solid organ injuries, things like kidney, spleen, and liver, that adequate access to a trauma center and early arrival to a trauma center would be the appropriate treatment for these. Okay. We've talked a lot about how bullets work, how bullets travel, what bullets can do in tissue. As you can imagine, what the bullet hits matters. If it hits something that's very vulnerable or very important, it's going to cause more damage. I don't have a whole lot of imaging that we involved in this study, but I just kind of want to show a little bit of what this looks like when a bullet hits bone. So this is a significant lower extremity wound causing a comminuted fracture, breaking that tibia into several different pieces, but similarly, that soft metal of the bullet also broke, and so you have fragments and pieces kind of all throughout after it struck the bone. I think an awful lot when we see these patients about where the hole is and where the bullet may have traveled. This is a patient I saw over in a foreign country. When we got this first film, I was absolutely terrified because this appears to be sitting right in his spinal canal. However, there is a rule in radiology that one film is no film. And so this is actually where it's at. This is a police officer who was very, very lucky, sustained a handgun injury to the neck. And it stayed very lateral, which is interesting because there is a lot of high stakes real estate here. Certainly we worry about the airway, we worry about the spinal cord and the central areas here, but once we start getting out into the lateral areas, we worry about the major blood vessels and nerves and arteries that are passing through here. And he got very fortunate and ended up sitting very, very lateral and didn't cause any significant damage. All right, I'm gonna bring this into the trauma bay now and start to say, okay, what matters is we're bringing this patient in, dropping this patient off, handing off. What are the things that the team at the hospital wants to know and maybe asking, but honestly doesn't need to know? Number one, we want to know the type of weapon if it's known, meaning handgun or rifle. That's the only thing that we want to know in that initial phase because it's going to determine, is this a low velocity, meaning no significant concern for cavitation, or high velocity rifle round where we are worried about cavitation? Do we need to be worried about areas of injury beyond just the path of the bullet? The caliber itself doesn't matter. My colleagues ask this question all of the time. I am encouraging them to stop asking this question. First of all, you're not going to be chasing down weapons or cartridges on the scene of these incidents, but the caliber doesn't matter. If it is a handgun versus a rifle, if we know that information, that is helpful. The size of the caliber does not matter. However, the number of holes and the location of these holes very much matters. The anatomy here is broad strokes. We're saying what lives under the hole and where may that bullet have potentially traveled. The images that we've looked at today, the videos we've looked at today are all through uniform, homogeneous ballistics gel. And even then you see the bullets turn, they curve, they fragment, pieces move all over the place. Again, this is broad strokes because when we talk about entering different types of tissues in the body or potentially any sort of hard tissues like bones where things are going to ricochet or change course, these become very, very unpredictable. So the question we want to know from your pre-hospital assessment is, what are the number of holes? What's their location? I worked in a hospital for a very long time that had a lot of penetrating trauma. For some reason, the desire at that hospital was always to ask the question, how many shots were heard or fired? I don't care. I only care about the number of holes. It doesn't matter what people hear. That number is never accurate. And then finally, I want to expect our injuries to be worse than they initially appear. Remember, if the bullet's going to deform, it's going to fragment, or it's going to cause cavitation, the injuries are going to be much more severe than you would necessarily initially appreciate just based on the bullet path alone. All right. I do want to introduce one sort of novel thing that I found really interesting that came out of the United Kingdom. This was a different approach to triage, especially in the setting of penetrating trauma. And they call this the 10-second triage. It's very interesting to me because it doesn't involve any physiology or any math. And that was very intentional on their part to say, if we were not trying to find any physiologic parameters, how fast is their heart rate, how fast is their respiratory rate, we are just looking at some very simple things. We can triage faster and we can teach more people to triage. You don't necessarily need to have an EMS background to use this triage tool. So this triage tool is really interesting. I'm just going to kind of introduce it today. But that is, number one, are you walking? If you are walking coming out of a mass penetrating injury, you are a 3, you are a low priority patient, move on. If you are not walking, do you have severe bleeding? If the answer is yes, we're going to go directly to bleeding control, and you are a red patient, you're a high priority patient. If you do not have severe bleeding, the question is, are you talking? The answer is yes. We're going to look for one final thing, and that is there penetrating trauma to the front or back of the torso? And they describe this including kind of the upper parts of the upper extremities and upper parts of the lower extremities where the blood vessels are still very, very big. If you have penetrating injury to that area, you are a priority 1, red patient. If you are talking but do not have a penetrating injury to that area, you are a yellow patient. And then finally, if you did not have significant bleeding, if you are not talking, are you breathing? If so, or able to breathe after we do a quick airway maneuver, we're going to place you in the recovery position and move you as a priority 1 red patient. If not breathing and not able to do so after a simple airway maneuver, we're still going to place you in the recovery position, but you are probably now a black patient. Interesting concept. I throw that out there again, kind of recognizing that I have not seen this used or adopted anywhere in the United States, but I found it to be kind of a novel approach to a way to consider triage in the era, especially of significant penetrating trauma or a mass shooting. Okay. I've talked an awful lot. I recognize there's a bunch of you on this and I can't see any of your faces. So I'm gonna put up some resources really briefly. These are the ones that I use. Interestingly, this paper from 1984 is the absolute best I found on theory and practice of wounds. It's obviously 40 years old, but it is a very, very interesting academic emergency medicine article specifically around wound ballistics. I can get anybody a copy if you were interested in looking at that, as well as some, these are the 2 trials from Reed Smith and his colleagues that I published the graphs from and we talked about. I'm going to pause there and see if we've got any questions. Eric, you're very quiet. What do you got for me?
I don't have anything in my chat or in my QA. It looks like you've done a very thorough job of explaining everything. I have thrown the evaluation in the chat, though.
Perfect. All right. Well, this is our opportunity. If anybody has any thoughts or questions, I am happy to chat. Otherwise, I will leave up this really pretty picture of one of our tactical teams doing night vision training and me being absolutely amazed at what my iPhone camera is able to capture in low light conditions.
Can you speak to the effectiveness of vests in EMS?
Very good question. So I think what we know from the military environment in particular is that ballistic armor works for what it covers. Obviously, ballistic armor is designed to cover what we call the box, but the area of the chest where the largest vessels, the heart, and kind of the vast majority of the lungs are living. In the world of EMS, I find vests to be very helpful if we're ever considering a violent situation that we're heading into. So going into an assault, domestic violence, anything like that, where we don't know if weapons are present or not. And so I think that it's a helpful thing for us to protocolize and practice using in that environment, as well as if there's ever a task force model where we're talking about police and EMS entering into a warm zone or a hot zone at the same time. This is something we train for in a couple of the cities around here, and I spend a lot of time thinking about and talking about, but we think about the school shooting in particular as an environment where there is one shooter who's moving constantly. That usually is an environment that if you have law enforcement around you, you can move into relatively safely because they are helping to protect you in the path that you are traveling in. But I wouldn't want to enter that safely, or I wouldn't want to enter that even with law enforcement without some sort of ballistic protection for myself. Vests are the most common. Obviously, they're usually swappable between providers of different sizes, so you can either have one issued to you or just issued to your apparatus. I do very much support their use. I don't have anything more about effectiveness other than to say that they are certainly a helpful addition to our environment if you've got them. They come in a bunch of different styles, and this is where we need some of our law enforcement colleagues to kind of help us pick the right style for our environment, whether it's something that's going to be primarily soft and Kevlar based, it's going to be much easier to wear for a longer period of time, or whether it's going to have something like a hard ballistic plate in it. A hard ballistic plate, it becomes heavier, becomes harder to wear for a longer period of time, but does offer more protection, especially when we're talking about higher velocity rounds. Great question. Thank you.
Sorry, I got to come off of mute. That was my fault.
That's okay.
Are you packing the neck pre-hospitally in the case of penetrating trauma? Why or why not?
Am I packing the neck? So question there being uncontrollable hemorrhage from the neck, or from a wound to the neck. The answer is yes, because unfortunately we don't have a whole lot more in the way of bleeding control. It should come as no surprise that tourniquets around the neck do not work. But in the setting of a penetrating wound to the neck, I'm going to very much try to use direct pressure and or wound packing. In my experience, the vast majority of these can be controlled by direct pressure, 1 or 2 fingers directly on where the bleeding is coming from. But an adjunct to that with something like wound packing or hemostatic gauze is great. But I would still very much focus on kind of directed pressure where that blood is coming from. Great question.
What are your thoughts on junctional tourniquets versus wound packing pressure?
Yeah, great question. My experience with junctional tourniquets is very limited, and every time I try to go and pull any sort of clinical trial data or military data on the junctional tourniquets, I find very little. I will tell you, I've personally tried out a handful of these, and I find them to be relatively difficult to use in a controlled setting of not on a bleeding patient. I'm just practicing putting this on myself or somebody else. I find them to be relatively finicky, which is the last thing I want in this environment. So I very, very much support wound packing and direct pressure. I think, there is some military application, some military use of junctional tourniquets right now. I've not seen a case to spend that kind of money on that, on those devices for the civilian environment. Again, because I think the data is not particularly great, and I think the devices themselves are a little bit tough to use. And I do know that wound packing and direct pressure works great.
I think that's all the questions that I have in the chats. Let's see.
Amazing. Well, again, thank you all for joining. Thank you for spending your Friday afternoon with me and part of your EMS week. So happy end of EMS week to you. And I am here either directly or via Eric if additional questions or things come up after today. And we will be posting this. If people don't know this already, I should have put this link up somewhere. I didn't. But we do have a Division of EMS YouTube page where we post a bunch of these webinars after the fact. So if there's ever one that you want to go back to and reference, look at some of them. You're talking to folks on your crew who weren't able to attend today and are interested in watching it. There's no CEH credit for watching a YouTube video, but the content is there, and we are happy to continue to make it available.
Thank you, Mike.
Absolutely. Thank you, everyone.
Thank you all. Have a great day.